Hi, everybody. My name is Michaela, and this is my case study presentation. My placement this semester is at the St. Louis University Hospital, the SLU Hospital off Grand, and it's an acute care placement. So I put the definition of acute care. Acute care is a branch of medicine that actively treats patients with severe short-term medical needs. And so the SLU Hospital is a Trauma 1 hospital. It has 365 beds, which is not super big, but our ICU is fairly large with 2 floors and 80 beds. There's high acuity, so lots of different patients coming in and out with lots of different conditions because it is Trauma 1. The average stay is about 4 to 5 days, but of course there are patients who will stay for, a few months, unfortunately, and then some that'll stay just for a day and get discharged. The caseload from our standpoint is a lot of stroke victims, lots of traumatic brain injuries from motor vehicle accidents, and just different types of excursions. And then we see a lot of patients with GI, cardiac, pulmonary diseases. A lot of the evaluations we do are a lot of swallowing, bedside swallow assessments and instrumentation, which I'll get into a little bit. But as far as different evaluations that we kind of do pen and paper in a room, would be the SLUMS, which is a cognitive screener, the mini mental, and then the WOB bedside for aphasia. And SLU does not have any protocol on certain assessments to use, so it's kind of just up to the clinician. I know that I brought in a few different dysarthria or like motor speech characteristic forms just to kind of get some terminology and better characterize what I'm seeing in a patient. But those are the 3 that we mainly use. So the learning objectives for today is to understand the roles of SLP in acute care, identify vital information on a chart review, understand typical PMV and swallowing evaluation protocol, and identify reasons for decannulating a patient. Assessment. Okay, so we do a lot of assessments, like 90% of our day is just evaluation and assessments because, we're the first line of defense before trickling down into rehab and speech therapy services. So the way that all starts is with a chart review. So the patient I chose today is patient 640. And I chose that because her room number is 640, and that's how we identify people. The first thing you want to do is start with this chart review. And I kind of put what the important aspects are of a chart review is, because you really could stay in there for an hour and know everything about this patient. For us, we definitely want to know the reason for the referral. So, why do the doctors think that this patient 640 needs a speech pathologist? The consult category. So, are we seeing them for swallowing? Are we seeing them for speech, for language, for cognition? Why do they want us to see her? Previous medical history, the symptoms she's presenting with, imaging results, specifically from, those disciplines I kind of listed, and they're right here, GI, neurology, pulmonary. Any notes from the doctor and the nurse. You want to know if they've been intubated before, and if so, for how long. And then you want to know about any past or present or future surgeries, and then their baseline diet, which can be a little tricky because, we don't really know anything about their baseline when these people are coming into the hospital. So that's tricky to find. But then you certainly want to know their current diet. And that's a lot of the times while we are consulted is because they don't have a current diet right now, and they're waiting on us to see how safely this person can swallow and eat to be on a diet. So for this patient 640, this is from our blue sticky note, I call it, and it's kind of like a running tab of the speech pathologist that any of us could look at and kind of know, okay, like what about 640 do we need to know? What pertains to us? What's relevant to speech therapy? And so this is kind of her story in terms of how it affects us. So she's a 75-year-old with a history of chronic kidney disease, stage 4, hypertension, type 2 diabetes, admitted on January 9th with symptoms and testing positive for COVID-19 infection. She was admitted to the ICU due to acute respiratory failure, likely to secondary to COVID pneumonia and pulmonary edema. She required intubation on January 30th, extubated on February 11th. A trach and a peg was placed on February 23rd. And then as of the 5th of March, she was tolerating the trach collar, and she was a reconsult. So I put this is our blue sticky because that's what we call it, our kind of, little cheat sheet of why this patient is here. And so she was a reconsult, which means we initially got her, and I'll kind of go into this for a swallow eval, She wasn't doing too great, so she was put on hold, and then we kind of got the consult to see her. This is her problem list. So it's literally called the problem list. It's like on all of her notes. And so there's a lot of information here, but I just thought that I would add this in here to just kind of show you how complex these patients really are. Okay, keep having to move myself around. Okay, so PO in the trach at the beginning. So at first, this is a note from the speech pathologist, so us. We initially got a consult for swallowing, and based on the swallowing evaluation, she was not a candidate for a PO. So I'll kind of read this last sentence. Recommend patient remain NPO with consideration for a feeding tube placement, given it is unclear when patients swallow will be functional enough to resume a PO diet. So we kind of made that recommendation. And so the doctors kind of made this pre-op note that said, what's sort of pre-op diagnosis, respiratory failure, which is why she was in here, and then also dysphagia. So she was unable to be weaned off the ventilator, and a tracheostomy and gastrostomy tube was offered. And so this last part is just kind of saying that the family gave verbal consent. And I'll just read this. Due to the nature of the diagnosis, a discussion of operative and non-operative treatment options, as well as the risks and benefits, was held with the patient's family. After discussing the options, risks, and benefits, the patient's family elected to undergo the operative intervention. Informed consent was obtained from the patient's family, and we proceeded to the operating room for treatment. So she got her her G tube and her tracheostomy tube. So this is kind of her timeline. This first part right here on the 12th, that's kind of the part we just went over. She was not a candidate for PO, and so she got a feeding tube. And then all of a sudden she was placed on the BiPAP machine, for respiratory reasons. And so in that case, she's not eligible to, see, she's not appropriate to see us. So we put her on hold. And so the rest of her hospital course, she was kind of back with us by March 9th, so it was a little bit. And then we were reconsulted for a PMV, so passing-mirror valve. And so we kind of did some passing-mirror valve things with her. Right here on the 10th, she regressed just a little bit with her stats. And so we didn't see her for a few days. And then she was tolerating the PMV well and really wanted to eat. So this was interesting because we initiated the swallow consult, which is not as typical. Obviously, normally you get the consult, but she really wanted to eat. We felt it was safe. And then these last 3 dates are kind of just the process of what her swallowing assessment and intervention kind of looked like in addition to the PMV. Her goals. So in a hospital, goals are a little different. They're not super measurable or, detailed. They're kind of cut and paste and cut and dry, because at the end of the day, the goals are just, how is this patient going to safely leave the hospital? So for her, patient, staff, family receive instruction and compensatory swallowing strategies and/or recommendations and verbalized understanding. Patient will tolerate the PMV. Patient to be independent baseline with functional swallow and be able to safely discharge to prior level of care. So for this, these were all good goals for her to leave the hospital knowing that we did our job. So the first thing you want to do in this assessment portion when you're going into a room, for us, this was initially for the PMV evaluation, is you want to go over these safety precautions. So you want to orientate the patient. You want to ask them their name, their birthday, maybe why they're in the hospital. You want to ask if they have any pain, and if they do, that you report it to the nurse. So for us, we are required to ask them to rate their pain out of a 1 out of 10 or 0 out of 10. And if it's above an 8, we are mandated to kind of just report that. And it's also important because with us, we are doing swallowing assessments. And so we require good positioning, and that means sitting the bed up. And, if someone complains of 10 out of 10 back pain, you should be conscious of that when you are sitting them up in the bed. Or maybe they can't sit up in the bed, they're in pain. Maybe they're not appropriate right now. So that's just really important. You want to make sure that you're always turning the bed alarm off if it's on, and that you're just putting the room back into its original condition. So turning that bed alarm back on and sitting that patient down if that's where you found them. So real quick, I want to go over the benefits of a passing-mirror valve. So it improves verbal communication and swallowing. It kind of restores a normal breathing pattern. It can improve your cough. It kind of expedites the process for being decannulated. It's kind of one of those prerequisites to know that if you're tolerating this, you can hopefully be decannulated and get that trach out in general. It improves swallowing and airflow, enhances smell and taste and sensation, and helps secretion management. Okay, so I kind of put this assessment and intervention together because in acute care, the lines do kind of bleed a little bit because you're not necessarily making a treatment plan. You're kind of doing an ongoing assessment the whole time that this patient is in the hospital. So this was on March 9th. We went in for the passing mirror valve. Here you can kind of see in the picture kind of what the trach looks like and with the valve and kind of where it is. So the first thing we do is we kind of collaborate with the nurse, or we collaborated with the nurse and asked if there was any updates, and there really wasn't. So we went ahead and went into the room. We did the safety precautions. We checked 640 stats, and you always want to be conscious of kind of how much oxygen they're on and what that kind of means. And for her, that was 8 liters at 28%, and she had a high humidity trach collar that she was wearing, and that just humidifies the air and hopefully makes those secretions a little less thick and more manageable. So we wanted to make sure the cuff was deflated, and it was. She was managing that for a few days already with it deflated. So that kind of was the reason we got consulted in the first place, because she was managing that. So, let's see if she can manage, another type of occlusion. The trach type that she had was a Shiley 8 millimeter. And then the next thing we did in this was we educated her. So we kind of talked about what a passing mirror valve does, what it works with, or how it works, what the benefits are, kind of like I just talked about on that last slide. And for them, the big thing is it gives them a voice. And for her, it certainly did that. So this first session, you really want to look at how they're tolerating it, how is their vocal quality, and you want to make sure you have suction close, because having this occlusion, that might cause a lot of secretions. There's a lot of now new pressure that the patient isn't used to. And so you want to just make sure that you have all the things you need to kind of keep the patient safe and make sure that you're cleaning up after them if it's necessary. And then this is kind of, like I said, an ongoing assessment. And then it'll help decannulation after. And so for 640, her tolerance was kind of actually really, really good this first time. So she had adequate tolerance, and for us, that just meant for a few minutes. And so we kind of did just 5 different trials. We put it on, we had her say a few things, take some good deep breaths, kind of go over some breathing strategies. And she, was doing okay. Her stats were still fine. And then we just kind of take it off to give her a rest. Like I said, we did that maybe 4 or 5 times. And just to make sure that, we weren't necessarily overdoing it, because this is a very different sensation and that they're not used to, especially her, because she had had the trach for a while. And so by the end of this assessment, we just recommended that she use the PMV with supervision only. She was not able to take it off herself either. So, we didn't want her wearing it when no one was around, in the event that she does desat and, she does need assistance. So then we heard a lot of eagerness to eat. So she had not eaten in a long time. And so she really wanted to see if she could do a swallow evaluation. And so this was interesting because we reached out to the doctors versus getting consulted. But we felt that things were going well enough, and that she was, she was a candidate and things were safe, and that we could perhaps do a swallowing evaluation if the doctors permitted it. And they did. So by this point, we're still seeing her for PMD, and that is still treatment that we have for her 5 days a week. And now we're also adding swallowing to the mix. And so during the swallowing bedside evaluation, she was also tolerating the PMD for about 30 minutes. So as we're kind of doing swallowing stuff now, she's also tolerating the PMD. So it's kind of like a double whammy there when we're seeing her. So we did all of our safety precautions. And then we kind of went into oral care. So given that 640 had not eaten in a while, she definitely needed some oral care done. She actually did not even have dentition. We were kind of waiting on that. And so just kind of think of when you're sick and you kind of have to breathe through your mouth, you kind of get all that gunk everywhere. That's the best way I can describe it for some of these patients who have been NPO for a long time. So we did that. We made sure that her stats were still good. We did an oral neck exam, and a laryngeal mech exam, which that's kind of just looking at their vocal quality, the strength of their cough. And for her, we used green dye with all of our trials. So for our thin liquids, our puree, and then our mech soft solids, we put green dye in them, which you do a lot for fees as well. But we did that because that kind of told us if we saw green dye out of her trach, we would know that that was being aspirated. And so that was a telltale sign of kind of her swallowing mechanisms, how strong it was and how functional it was. So we did the swallowing trials with her, and her mental status was improved. She was more alert, more excited. And yes, like I said, she hadn't eaten in a while and it had actually been 32 days. So she was definitely eager. So we did not see any green come out of that trach, which was awesome. So to put it simply, I kind of just put roughly what we saw. So the oral phase was great. Her pharyngeal phase, she definitely had a decrease or reduce laryngeal excursion to palpation. And that's kind of just to be expected given the weakness and not swallowing as efficiently and just purely as much, exercising those muscles. And she had multiple swallows per bolus. Her signs of aspiration, she had one cough noted after thin. And again, that's kind of to be expected. That doesn't warrant a lot of concern. And she had no clinical signs of aspiration further. And so, we, you know, in a perfect world, you could feel great about that. But considering 640's hospital course, she is at risk for more silent aspiration due to her trach tube. And she, you know, she does have a lot of weakness, as I said, and you just want to be sure that, you know, you're using, again, kind of that evidence-based and that data-driven decision making. And so for her, we did proceed to just do an instrumental just to be sure, since it had been so long, despite that she did well at the bedside. So an MBS. So again, during this, we're still trialing, or not even trialing, we're still doing treatment with the PMV, and that really means just wearing it and kind of knowing what those signs are to look out for. So she was wearing it when she was eating, kind of for reasons we already spoke about, how it does kind of enhance that sensation and is better for that oral pressure and pharyngeal pressure. So she did the MBS and she did very well. This is kind of the note, and I'll just read it. Patient presents with mild oropharyngeal dysphagia characterized by prolonged disorganization, mastication of solids, delayed AP transit across consistencies, ×1 instance of deep laryngeal penetration of thin liquids after initial swallow. Giving contrast was noted to fall from the base of the tongue into the laryngeal vestibule. We will recommend initiation of a puree diet, which is dysphagia 1, with thin liquids. And then patient is to follow the strict aspiration precautions listed below. And then the SLP will follow for tolerance. So she did do well. She did not aspirate at all in the study. She did penetrate a little bit, but we did clear her for a puree diet. In dysphagia 1, you know, that is the lowest diet, I guess, possible aside from being MPO. So she was able to have PO intake though, at least. So she's on a diet, now what? So now we really have to consider, you know, what does intervention look like for swallowing? And so our first goal is diet tolerance. You know, once we put her on the diet, we wanted to make sure that we're checking in the next day and seeing how that's going. We're watching her at the bedside. We're making sure that we're not seeing any clinical signs of aspiration and that she feels okay with the diet as well. And so I put tray or PO. So I kind of wanted to ask you all, maybe when we talk, what considerations do you think should be made? You know, what do you think, you know, why do you think you should see a patient with a breakfast tray or a lunch tray versus going in with your applesauce and your, you know, graham cracker? Because those might tell you different things, or maybe not. I don't know. I kind of want to hear your thoughts, because I will say that we did see her with a tray, and if she didn't have a tray, we would actually leave him and then we would come back. So I'm curious to hear your thoughts about why you think maybe we did that. And I said, reminder, she's only on dysphagia 1. That's the lowest diet. So that's kind of a little bit of a hint. So exercises. So for her, because her swallow was functional, we did not have to do any maneuvers or exercises with her. It was purely just diet tolerance. And then again, we are still kind of looking out on the PMV. And by this point, she is able to tolerate and wear it without supervision. So she is wearing it for most of the day, of course, not when she's sleeping, but she does not need to have someone in there when it's on. And I put the visits are about 8 to 20 minutes long, just to kind of know how long we're seeing her with the PMV. When we're seeing these patients, a little caveat is it's just a glimpse into their day and certainly their life. So, we're seeing she does great with food when we're in there. We don't know everything that's happening on the outside, and we're seeing great she's doing with the PMV when she's in there. We don't know how it's going otherwise, but we assume that things are going well, given that her doctors and other team members are saying that everything is safe. So at this point, she has a barrier to discharge. We're seeing her 5 days a week for her PMV and diet tolerance and upgrade. And we have also recommended that she get services at her skilled nursing facility, and physical therapy and occupational therapy have also recommended that. So she is eligible on our end. However, she has been denied from so many places, and her insurance is trying to appeal for a long-term acute care, which is an LTAC. And so she's been denied due to new trach, high O2 requirement, and frequent suctioning. So I kind of just point this out because from a medical standpoint on our end, we felt she's appropriate to discharge, but there is a little discrepancy between, why facilities won't take her. And so I think that's just a really good learning point to know that, even though we know she's satting well and she's on a PMV, that might still be a concern for some facilities. Another reason was that there are a lot of facilities that were too full, which is kind of just stinks because she had already been in the hospital a really long time. And we only met her daughter one time, because I just want to point that out, because especially with discharge, family members are always kind of wanting to know, when can, my loved one get out of the hospital? And we only met her daughter one time. We don't collaborate a ton with family members. That's kind of something more that social work and the care coordinator will do, is, talk to that daughter, because she was obviously trying to be an advocate for her mom to get her out of there. But in a way, we are super happy that she did not get discharged a few weeks ago, because since then she's been able to upgrade to a regular diet. So incrementally, she has gone to dysphagia 1, dysphagia 2, dysphagia 3, and then we have another step of mechanical soft, and then a regular diet, while staying on thin liquids the entire time, which is great progress. Again, especially for somebody with such an intense hospital course and intubation. She's tolerating the PMV without assistance, and she is still she still does have the trach, and to my knowledge, it's not being decannulated anytime soon. But that being said, she is finally awaiting placement from an LTAC, which is encouraging. And, they do take people with trachs, and that's not uncommon. So we know that she'll get good care there, even if she's not decannulated by the time she gets there. And she did meet all of her goals, like the goals that we kind of talked about, with being on the least restrictive diet, being able to do any compensatory strategies, which we did educate her on, kind of what to do if certain things do arise, but she did not really need any. And then also, tolerate her PMV. So she's in good shape right now. And when I meant to make this video, she had discharge orders. So I went ahead and completed this project because I'm very hopeful that she will go. So in summary, 640's SLP course consisted of PMV tolerance and knowledge, trach management, and PO candidacy. And I chose her kind of in the first place because she did have a trach, and those patients are really interesting to me. And you never really know how their course will go. People can have trachs for a very short amount of time and then very long amount of time. And for her, she still has it. And it was very interesting, and I'm happy that I did choose her because she was an advocate for herself and, wanting to get a swallow assessment, which is really unique in acute care because these patients are so medically fragile. And so I thought that was really neat to kind of see her, be proactive about her own health and her quality of life while she was in the hospital. Overall, I hope you learned some things. These were kind of the objectives, so just going over those again. Identify vital information on a chart review. What were her goals and were they met? And yes, they were. Understand the roles of a SLP in acute care setting. understand typical PMV and swallow evaluation protocol, and identify reasons or barriers for potential discharges. So that's all for me. I hope you guys enjoyed and learned something, and I will see you guys in class. Bye.